Hello, my name is David Bishop, and I'll be speaking to you today on district anesthesia for the evacuation of the uterus. Now, this is the district anesthesia education channel where these videos are found. I'd encourage you just to check out some of the other videos that we've got there. It's not only me speaking, it's some other people as well, and it's essentially topics that I believe are relevant to people giving anesthesia in the district hospital setting. And it's really pitched at occasional anaesthetists or beginner anaesthetists rather than the experienced anaesthetist with a qualification. Now, we're going to be dealing today with incomplete miscarriage when products of conception are not expelled through the cervix. I won't be covering manual removal of the retained placenta simply because that's a different procedure. It needs to be done in theatre, and the choice of anesthesia, there's slightly different implications. And I'll cover that on another day in another fashion. The procedure we're going to be looking at is curettage or vacuum aspiration. And the anesthetic techniques are mainly I'm going to be focusing on sedation, a little bit on general anesthesia, and I'll mention regional or paracervical block anesthetic techniques, but I'm not going to spend a lot of time on those particular techniques. Now, this is an important problem in South Africa. There were 323 early pregnancy deaths in 2017 to 2019, and 204 of them were complications of miscarriages. And that constitutes a 24% increase on the previous triennium. These are the highest numbers of early pregnancy deaths that have been recorded in any triennium since the confidential inquiry process began in South Africa in 1998. And more than a third of these deaths were clearly avoidable. So it's a major issue in South Africa. 29% of them occur in district hospitals. So this is very much a district hospital problem. And it's for a procedure where we should be aiming for almost a zero mortality. So the number one focus is to avoid maternal mortality. And we do that by doing two things better. We need to identify sick patients better and manage them appropriately. And then we need to have safe practice on our healthy patients. Most of the patients that are dying are the sick patients, but occasionally there are events that are occurring in healthy patients that shouldn't be having poor outcomes. So that's one of the major focuses. Secondly, when we're anesthetizing these patients, we need to avoid maternal discomfort. And it's important to recognize that this procedure is not a procedure that is a comfortable procedure for mothers undergoing it. It's difficult to maintain their own dignity. They're up in stirrups, and if they're wide awake with a number of staff around them, it can be quite an embarrassing procedure to go through. And so one needs to maintain one's professionalism, and often it's nicer for those patients to be asleep. It is a painful procedure, perhaps not as painful as a surgical incision, but there is a significant amount of discomfort that we need to manage. And finally, one needs to remember that underlying all of this, there will be a grieving process going on in these patients, whether they've had a termination of pregnancy or they've lost a child. Either way, it's a traumatic procedure. No matter what choices they've made, there will be grieving. And we need to be cognizant of that, and we need to handle these patients with sensitivity. And finally, it's an opportunity to improve the service. And that means improving the environment where we do these procedures. We can set up better, we can generally do better, especially if we're doing these things in the ward. And we can use as an opportunity to improve the skill set of the staff working in the hospital. So if you're able to do a general anesthetic, bring someone along and train them while you're doing this, because this is a very good procedure to teach on. Now, the first question you want to ask yourself is, there's four basic questions you want to ask when you approach each patient. How is my patient? What procedure am I aiming to do? What anesthetic do I think I'm going to do? And where should I be doing the procedure in the anesthetic? And you should ask these questions every single time you see a patient. How is my patient is a very important question to ask. You cannot assume that every anesthetic technique or every procedure can be done in the same way for every single patient. So the first thing you want to look at is clinical parameters. Now, obviously, you'll examine the whole patient, but pay particular attention to the heart rate, the blood pressure, and you can, using those two indices, you can work out the shock index as we've covered previously. Look at the respiratory rate. High respiratory rates should always concern you. It's a very good predictor for poor outcomes. So tachypneic patients need to be treated with extra care. And finally, the GCS. Patients should be fully alert and conscious. If they're anything else, even drowsy, take that as a marker for severe illness and treat them appropriately. Treat them as sick patients. Investigations, you need at least a ward hemoglobin. I've put query more because if they are sick patients, then you need to start thinking about doing full blood counts, coagulation profiles, looking at the renal function. But in a standard procedure, a ward hemoglobin is enough. And then think about other problems. Is the patient elderly? Is the patient obese? Obese patients often constitute a special risk group. And what's your gut feel? Sometimes you just know that a patient is sick. And pay attention to these feelings that you have when you examine these patients. And you want to finish this examination thinking, am I worried? Is there something in me that thinks this patient is slightly sicker than the average patient that I see? When we have 5 of these booked in a theatre slate in my regional hospital, I always assume that one of them is sick. One of them is critically unwell. And it's actually quite difficult to pick them up sometimes. So you have to examine them thinking, is this the patient that is going to complicate? And really you need to have that high index of suspicion. In particular, you're trying to pick up the septic patient. Often difficult to do. And when you detect the septic patient, that's the patient to pay attention to. Also, when you're examining them, do they have chronic illnesses? Again, patients with chronic illnesses may mean you need to do this in a higher care environment, like in theatre rather than the ward. If you've got what you feel is a sick patient, there are a number of things that you need to pay attention to before you go to theatre. Now, firstly, you are going to theatre with these patients. Sepsis and hemorrhage have slightly different approaches, slightly different forms of resuscitation. So ask yourself those questions. Do I think this patient is septic? Do I think this patient is bleeding? Or do I have a combination of the two? The first thing you want to make sure is that the patient has had adequate fluid resuscitation. And usually that means giving them modified Ringer's lactate. Sometimes these patients need 1 liter, sometimes they need 2. But pay attention to the fluid resuscitation. I've put an hourglass there just to remind you that we are on a time frame. A rapidly bleeding patient really just needs to be resuscitated on the way to theatre. A patient who's not actively bleeding or who is septic can be resuscitated first. And in terms of your time frames, you're looking at around 6 hours. You can resuscitate these patients in about 6 hours or up to 6 hours until you get your clinical endpoints, until you meet those endpoints. Aim to optimize the HB. Probably a good number is to aim for around 7 with blood available. It's better not to go to theatre with HBs that are very low. Again, if the patient's bleeding actively, you transfuse or get blood on the way to theatre. But if the patient's not bleeding very quickly, you can often catch up. So transfuse first or just get that HB as close to a 7 as you can. In septic patients, once you've given fluid and you've optimized the HB, consider adrenaline. You shouldn't only give fluid resuscitation to a septic patient because often they require some degree of vasoconstriction. So have a fairly low threshold for adrenaline, and those recipes for adrenaline are available in that ectopic talk that we've given and also the article that we wrote that's attached to that. When you've got a sick patient and you're concerned, remember you do have time to pick up the phone. So you can phone an anaesthetist if the concerns are anesthetic, or an obstetrician if your concerns are gynecological in nature, but you've got time to discuss. And remember, in a district hospital also there will be seniors on the property that may have more experience than you in this area. Pick up the phone or get them to come and see the patient with you. That's the time to talk before you start the procedure. And finally, remember that as soon as you're worried about patients, don't do them in the ward. Take them to theatre because the setup is there. You've got all the equipment that you need. If you complicate, you've got a ventilator. Don't try and get away with these procedures in the ward. Now, in terms of targets, I usually aim for a hemoglobin that's around 7, a heart rate that's under 120, and a systolic blood pressure that's approaching 100 or just over 100. I'm aiming for a GCS of 15. When we go to theatre and we haven't met those targets, you just need to put your mindset in that frame that I'm dealing with a critically ill patient and treat them like critically ill patients. And sometimes it means referral out of the district setting. Sometimes it means stabilization in the theatre at your setting. And that's an individual assessment. So what procedure am I doing? Just remember, there's manual vacuum aspirations, which can be done in the ward, or potentially going to theatre for curettage. Are you going to dilate the cervix? If you are, that is a more painful procedure, and you need to get a level at least up to T10 if you're doing regional anesthesia, or you need to perhaps give slightly more analgesia to that procedure. Most of the pain is a visceral pain in nature. It's not like a surgical incision, but it is definitely uncomfortable. Is this patient at risk of complications, especially the septic patient? And do I think that proceed to total abdominal hysterectomy is something that I need to consider? And again, if that's in your mind, you either need to be in theatre or you need to be referring this patient. There are a number of things that are specific to the evacuation of the uterus. Remember, I've just mentioned T10 pain if you're going to dilate the cervix. The patient's going to be up in stirrups. That's not dignified. So you need to be aware of that and counsel the mother around that and potentially put her to sleep if you're in theatre. And then finally, there's a number of stimulations that occur. Dilation of the cervix can cause vagal stimulation, so you can see bradycardias, and you might need to treat that with atropine or glycopyrrolate. And then you also get sympathetic stimulation, and that can cause laryngospasm rarely. And just be aware of these complications, because wherever you're doing these procedures, you need to be able to handle those complications. So which anesthetic are you going to do? I'm going to break these down a little bit further, but you're really choosing between a GA, sedation, or regional procedures. Now, regional procedures like a spinal anesthetic, a low spinal anesthetic, are perfectly acceptable for this procedure, although you would want to be in theatre for that. You can't do that in the ward. I'm not going to deal with paracervical blocks, as I've mentioned before. So predominantly, these procedures are done under sedation. And I'm going to spend most of my time talking about that. When you look at which method of anesthesia is best, this is from the Cochrane review. Essentially, this review found that there was no difference between the three techniques in terms of how patients had experienced them or had the experience of postoperative pain, except that the general anesthetic seemed to be what patients preferred. And that's really for obvious reasons. But it wasn't there weren't massive effects. If you use opioids, that was definitely associated with nausea and vomiting post-procedure. And the paracervical block didn't give any advantage over these other two techniques. So where should this be done? If you're going to do it in theatre, that's obviously the ideal situation, but I know many of you are doing these procedures in the ward when you're using a manual vacuum aspiration. If you're going to be working in the ward, can you set up a procedure room? Because what you want to be doing is hoping for the best, preparing for the worst. And you need to be able to handle complications when they occur in the ward. As a general rule, have a low threshold for going to a better environment. ASA 3s to 4, so people with chronic illness, the obese, the elderly, the sick patients, those patients should generally be done in a different setting, not necessarily because of the procedure, but because of the anesthetic risk. And this relies on a thorough preoperative assessment. So you have to see these patients well, and you have to think about these questions. What am I going to do when things go wrong? If you're in the ward or the procedure room and you're just using a sedation only technique, this is the document you probably want to read at some point. It's the SASA sedation guidelines for the safe use of procedural sedation and analgesia. This is the 2020 to 2025 version, and I'm going to be mainly drawing on some of the principles from this document. It's an excellent document if you're wanting to learn about sedation. If you're a beginner sedationist, practice in theatre, not in the ward. Everything's there. Or practice with somebody, one of your colleagues that is good at sedation, and have 2 pairs of hands so that you've got someone to help you, because in the beginning sedation is actually quite difficult. Anaesthetists find a general anesthetic easier to do than sedation in the ward, and there are lessons to be learned from that. So when you're sedating, you have to remember that it's all a continuum, and you start at minimal sedation and you work your way through to general anesthesia. And it's quite easy to move between these states, and you're aiming for minimal sedation or moderate sedation, which is called conscious sedation, but you can give slightly too much and suddenly you're actually giving a general anesthetic. So we assess these things by how responsive the patient is, whether they're maintaining their own airway and breathing on their own, and how their cardiovascular system is coping. And as you move from left to right and you get deeper and deeper, the risk of complications goes up with increasing depth, and you need more equipment, more monitoring, and you need a better skill set or a more advanced skill set. So you don't want to be moving unintentionally to the right of this graph. And complications occur because the sedation practitioner is inexperienced, or you've chosen the wrong patient, or you haven't prepared, or the procedure is the wrong one for sedation. You've used too many drugs on the same patient, or too much of that drug. We don't have the right monitors on. You're unable to rescue when complications occur. All of these things you need to think about before you start sedating. And that's why you need to choose that technique very, very carefully. So there's really 2 categories of sedation. There's basic sedation and there's advanced sedation. Now, basic sedation is the sedation that you will be doing in the ward when you're doing these procedures there. Advanced sedation must be done in theatre. And the first differentiator is that you're only using a single agent for basic sedation. And by single agent, I mean if you're choosing a benzodiazepine for sedation, you can't add an opioid to that. If you add paracetamol or diclofenac to that's not a sedating agent, but you can't add a Midazolam or diazepam to something like ketamine or an opioid and be in the ward. Advanced sedation, 2 agents, or you're using an induction agent. So anytime you use propofol, it is advanced sedation. You may not use propofol as part of a basic sedation technique. Basic sedation can just be done with clinical monitoring. So somebody watching the patient, talking to the patient, making sure they're breathing. And generally, it's a good idea to put monitors on if you have to, but they're not mandatory. Advanced sedation must have NIBP, pulse oximetry, and you need a fasted patient. Fasting for the basic sedation is advised, but not mandatory. Basic sedation can be done with a single operator. So if you're doing the procedure and the sedation, generally you'll have someone else with you, but it is permissible to do it with a single operator, provided the procedure is less than 30 minutes long. If you're doing advanced sedation, you must have someone who is purely watching the sedation, because the risk here is that the patient is going to stop breathing. And if you're doing the procedure, you'll get a fixation error. You'll be concentrating on the procedure. And when you look up, the patient will have been apneic for too long. So you must have a separate sedationist for advanced sedation. In basic sedation, you're aiming for a conscious patient that can respond to you. If you said to them, how are you feeling? They should be able to give you a thumbs up. Advanced sedation is deeper, where they're not really rousable even to painful stimuli. And for that one, you must be in theatre. So think, which technique are you aiming to do in the setting that you're in? And be very clear about which one you're picking. And as soon as you go into those advanced sedation techniques, make sure someone else is with you. Some of the principles: there's a lot of inter-individual variation with sedation. And titration eliminates guesswork. So you must titrate. So start low, go slow. Ketamine is not advised for single operator sedation practitioners, but I know this is being done in the district hospitals. If you do use it, give it slowly. If you give it rapidly, a big dose rapidly, they can actually get intense respiratory depression and apnea. I'll come back to that. Sedation is not analgesia. Just remember that when you give a benzodiazepine, it's not doing anything for pain. Restless patients need attention. Often you think they're disinhibited because you've given sedation, when they might actually be hypoxic or have a low blood pressure. So when they become restless, stop, assess them, get monitors on them. About 15% of people will have an excitatory reaction to a benzodiazepine. So it is quite common, but don't be caught by the fact that actually maybe there's another problem going on. Ketamine I've just mentioned. If you're going to use it low and slow, so 0.5 milligram per kilogram, give it time to work and see the response. If you're using diazepam, this is probably not the agent that you should be using for titrated sedation, because there's a very varying context-sensitive half-life, meaning that if you give more and more, the half-life changes. And the diazepam half-life can be around 50 hours, but the peak effect duration is only around an hour. And many people are using diazepam and then following it up with flumazenol as reversal. Just remember that flumazenol works for about an hour. So if that diazepam hangs around, the flumazenol wears off and they get resedated. So it's better to not use the flumazenol, and then you know where your patient is. Or use flumazenol, but then you must review that patient. An hour or two later, go back and review that patient. And it's one of the reasons why I prefer Midazolam to diazepam when I'm using benzodiazepine sedation. And finally, consider discharge criteria. Don't let that patient go to the ward or leave a monitored care setting if they're deep. And if you're going to send them home, remember that after 24 hours after sedation, they're not allowed to drive, they can't use heavy machinery, they shouldn't drink alcohol, and they shouldn't sign a legal document. In rural locations, if they don't have access to transport or a telephone, you should admit them for 24 hours. So you have to keep them until they're safe to go home. This is just to remind you that if you're using diazepam for sedation, as you give more and more, that half-life or the half-time goes up exponentially with an increasing dose, whereas midazolam plateaus. So eventually, even if you've been giving a lot of midazolam, the half-time stops going up. And these are things to consider when you're choosing your agent. So ideally, don't use diazepam in the ward. And just to mention ketofol, a lot of people are using ketofol. SASA sedation guidelines suggest a 10-to-1 ratio, so you'd use 100 milligrams of propofol with 10 milligrams of ketamine. People are mixing this up as a 5-to-1, as a 1-to-1. It definitely is a better drug for continuous intravenous sedation in adults undergoing surgery. It minimizes respiratory depression. But what I really want to stress is that if you're using propofol, you cannot be in the ward and you cannot be doing single operated techniques. This requires a sedationist or somebody watching the patient while the other person does the procedure. And it's a nice mix to use. It's worth using, but please use it in theatre and at least 2 people in the theatre. Now I'm going to finish off just by telling you what I would do in different scenarios. These are by no means rules. They're just what I use when I'm in different scenarios, and you're very welcome to use different techniques depending on what your skill set is and what you're doing. If I was in the ward, and I don't really do these procedures in the ward, but if I was, I would be using, and I was doing a single operated procedure, I would be using midazolam titrations, and I would probably start with 2.5 milligrams, and I would give a milligram at a time while I titrated to effect. I would get some background analgesia on board, paracetamol and diclofenac, but I would not be using ketamine or an opioid in combination with the midazolam. And personally, I would find a way to put monitors on these patients. So I would have a non-invasive blood pressure and a pulse oximeter on all my patients, just because that's the way I'd like to do things. I don't think it's that hard to get a multi-parameter monitor on a trolley in a district hospital. You just have to be set up, and I would aim to do that. If I was going to theatre and putting in a spinal, I would generally not be sedating these patients. Usually we've picked a spinal because we are concerned about anesthetic skills, and I would use 1.5 to 2 mils of heavy Marcan. Hyperbaric bupivacaine, 0.5%. 1.5 mils is probably fine. I put that in and have the patient there, and I could have a nurse anesthetist watching the patient, talking to the patient while I did the procedure. And I used to do this in the district hospitals, and I found it very satisfactory. It's not quite as quick, but it's a very safe technique. That technique would obviously be for healthy patients. You wouldn't do that in tachycardic patients or patients that you'd have to resuscitate. If I was doing sedation in theatre, this is my own recipe. This is what I tended to do. I would take a 5 milligram amp of Midazolam and give half the amp, and I'd give half an amp of fentanyl. So it was 2.5 milligrams of Midazolam and 50 mics of fentanyl before they started. I then put the patient up in stirrups, and I would give 3 to 4 mils of propofol as required. It usually was every 3 to 4 minutes, and I would hold an oxygen mask on the patient's face, and I would occasionally need to support respiration with the mask ventilation. So I was actively watching the patient's respiration. I had capnometry on all these patients, and it's a very nice technique if you've got a long list to do. It works very nicely. It's also a good list for learning to maintain the airway. If I was doing a GA in a healthy patient, I would either do that method that I've just told you about with just a little bit of extra propofol, even ketofol, or I would pop an LMA in and I would let these patients breathe spontaneously with a low amount of volatile, just enough to tolerate the volatile, and I'd give fentanyl a mic per kilogram just before they start the procedure. That'll last 20 minutes, and usually they go very smoothly as well, and that enables me to have a hands-free technique if I need to do other things around the theatre. And finally, just to mention that if I'm doing a patient who's very sick for an evac of the uterus, I'll do a full GA for these patients, which includes an endotracheal tube and mandatory ventilation. I'll tend to use a ketamine induction, and that's probably what you should be doing in the district hospital. You keep the volatile anesthetic very, very low. So maybe if you're using isoflurane, an end tidal max start at about 0.3. Generally, you don't need to paralyze these patients after you've done your induction, which is usually with succinylthonium. So after about 10 minutes, if the patient's too light, you'll know it. I'll use fentanyl as required, and I'll continue with the resuscitation and focus on the resuscitation. Fluids, blood, adrenaline if I need it. And I will try and get some form of arterial blood gas to see how sick this patient is and whether I'm going to be able to extubate or I need to transfer intubated to the regional referral center. And don't forget that during this procedure, there'll be multiple times to ask for advice. So get on the phone either with a friendly anesthetist or a friendly obstetrician, if you've got one in your back pocket, and get these people involved. And that's where I'm going to leave it. That's a very simple overview of how I suggest you do evacuations of the uterus. Remember that other topics such as the ectopic pregnancy and the GA for obstetric Caesar are covered in other talks on this channel. Thank you very much.